Okay, well, here we are back again for the 15th year of the Smoky Mountain Respiratory and Sleep Symposium. I thank Zach and his staff for having me back. You know, over the years, I look out over the crowd and I've done various presentations and see people that have nodded off because I've got a slightly monotone voice, and so every year I'm even more surprised to be asked back. So you can see that when I started doing this, I had brown hair and then it turned gray and now it's almost white. So after 15 years, you know, we've gotten a whole lot of water under the bridge and a whole lot of topics that we've covered, and we're glad we made it through COVID and we made it through some really lean times. Here we go. So today we're going to talk about something that is kind of special to me, because in the first 7 years that I worked from 91 to 1998 on night shift, I found a day job in 1998 and decided, okay, I'm going to come off of nights. And I noticed real quickly that, you know, two things happened that were kind of, one was expected, one wasn't. One, I couldn't sleep through the night for about 6 months. But the second one was I would have sleep paralysis all the time. Just got used to it. But I developed a really keen interest in it, and so that's why I wanted to cover this today. And what we're going to talk about today is, if you don't know already, some of you do, maybe many of you do, but isolated sleep paralysis is that paralysis that has nothing to do with anything else, not with narcolepsy, not with hypo-K, not with hyper-K, not with lots of other things that we'll cover. And what you're going to see as we progress through the presentation is that identifying and tagging sleep paralysis as a diagnosis all its own, even though it's a fairly benign thing for most people that don't have a history of trauma or PTSD or, you know, some other things that we'll talk about. Even though it's very benign, you have to peel back the diagnosis and really make sure that if you're doing a differential that you've ruled out lots of other things, especially if someone's predisposed to having covariating factors that we'll show on one or two of the slides. I don't have any conflicts or disclosures to reveal. If I did, I might not be here. Better supported somewhere else. But in all seriousness, for hundreds, even thousands of years, there's recorded history of what we now know as sleep paralysis. This is the 18th century artwork of Henry Fuseli. It's called The Nightmare, but obviously the posture of the subject and the incubus sitting on the chest and so forth, you know, leads us to realize that this is just one example of many that reach back several centuries, even thousands of millennia. We'll cover in one of the nearly last parts of the slide deck some cultural, you know, worldwide explanations of sleep paralysis and how historically folks assign their own interpretations of them. Okay? So, our session objectives. Pretty simple, pretty broad. Understand the differences between isolated sleep paralysis and that which goes with narcolepsy or other diagnoses. Explain the various influences, cofactors, correlates of recurrent isolated sleep paralysis. And when I say recurrent, it's like I had it over and over and over again for about the first year until my sleep hygiene improved. After that, we're going to review a case study, really an observational study. It wasn't a peer-reviewed thing or anything, but about the time that I came off of nights, I thought, well, I want to do something with this. And, you know, in all honesty, in all transparency, as we say in hospital lingo, I wanted to try to get something drafted so I could get myself into, you know, working with sleep review. So I did this study of nurses at 350-bed hospital in Chattanooga, and we'll talk about the details of it. And then finally, we'll identify and briefly discuss some of the common treatments, and really most are non-pharmacological, as you can imagine. Mostly have to do with sleep hygiene and things that are behavioral, and for many people, things that they just don't want to do. But we'll get to that. And then there's one other part of this that deals with, and I forgot to put it on here, deals with some of the more pop culture type explanations of sleep paralysis and the motor vestibular hallucinations. And when we get there, you'll know, and I'll discuss it. Some of you may even know the person that I'm going to highlight. Okay, so sleep paralysis, of course, is the resumption of wakefulness out of REM. Just like with narcolepsy, and this is why it's part of why it's so hard to partition it. If somebody has not had a diagnosis of narcolepsy, but they perhaps have hypersomnia with some, sleep paralysis, kind of like somebody who's a shift worker. So what you've got going on there is really a fight between three neurotransmitters: acetylcholine, serotonin, and hypocretin. Okay, and the explanation of all that is something Gabe could done very, very well, and I really appreciate him coming every year. He's been here as much as I have, and he always gives a presentation that's, not, to say it any other way, not dumbed down. It's really like you could present it to medical students or other physicians, and I really appreciate that. He and I worked together briefly in Chattanooga when he was there. But anyway, the episodes almost always, for folks, include some sort of hallucinatory effect. We'll talk about that. Folks are unable to move or speak. And if this happens to you for the very first time, it's very troubling. And for people that have got a background with psychological or physical trauma, the effects can be heightened. The state of dissociation makes your brain, in simplest terms, fill in the blanks. And so that's where the hallucinations come, and that's, whether they're olfactory, tactile, with the incubus, or auditory, or what have you. Possibly the more magnified they can be, depending on your background as a patient. Okay, so the most common, as we saw in Fuseli's drawing or artwork, intruder hallucinations, motor vestibular hallucinations. This is one of the ones in the middle that I had, that I became accustomed to dealing with, is that I had this feeling of spinning upside down and backwards, almost like an outer body thing. And we'll, again, talk about that a little bit more related to pop culture, just kind of break it up a little bit. And then, of course, the chest pressure feeling that so many people report. And 3/4 of folks, they have one or all three of these. So, versus narcolepsy. Okay, so narcolepsy, as we know, has got hallmark symptoms. Recurrent isolated sleep paralysis is isolated, just that. So we know that we don't have cataplexy. We know that we don't have sleep attacks. We know that we don't have irregular levels of hypocretin if somebody were to do a lumbar puncture on someone and look at the cerebral spinal fluid. There's a high correlation to patients and susceptibility, folks with schizophrenia, bipolar disorder, and other forms of mental illness, as much as 30% higher in some studies. The classification, of course, within the world of sleep medicine does fall under parasomnia. It does have its own ICD-10 code, and we'll get to that in a minute. And again, like leg problems, the incidence, reported incidence at least, is a little higher for females than males. And again, we're not sure why. Okay, so compared to narcolepsy, the factors that surround both, one's going to lead to probably heightened anxiety, while the other is something you can go right back to sleep. So if you have, for example, a hypnagogic or a hypnopompic hallucination with sleep paralysis and narcolepsy, because of your narcolepsy, you're going to be able to go right back to sleep despite how anxious you are. And the folks that have got just an isolated form of sleep paralysis, that insomnia, or excuse me, that panicky feeling and the anxiety associated with that can cause, not a correlation, but a generalization of that panic with bedtime. And so once you get that and fall into that behavior, especially if this is recurrent sleep paralysis, then you can see that insomnia and going to bed all of a sudden is a negatively reinforced behavior that folks just have to almost break out of and either seek cognitive behavioral therapy or some kind of pharmaceutical therapy to get past it. The pharmaceutical treatments almost always include basically REM suppressants, tricyclic antidepressants, some SSRIs, and there's narcolepsy. Any of the disruptions in narcolepsy that would include cataplexy, the Xyrem or the sodium oxybate is, of course, what's going to be prescribed to control that cataplexy. And this is where it gets fun. The most eccentric explanations of the motor vestibular hallucinations people have extrapolated into being outer body experiences, and actually the upside down spinning that I experienced was kind of like that. And if you've ever had anybody that's had a near-death experience, then you may have heard similar anecdotes and stories. But there's one fellow in particular that I learned about who's an entertainer while I was on night shift, and he had built almost a whole career on outer body experiences. We'll talk about him in a minute. I thought it was the next slide. But in differentiating, again, sleep paralysis from other sleep disorders, is we know with narcolepsy in kids and in young adults, it can take almost 10 to 20 years to get an accurate diagnosis. So there's lots of little things, not so little really, but lots of other disorders that you've got to rule out before you can assign a simple, benign diagnosis of isolated sleep paralysis. I have a stepson, for example, who has type 2 narcolepsy. He was having, before he was diagnosed, periods of sleep paralysis, but he otherwise didn't have any symptoms. He just, except for the hypersomnia. He didn't have sleep attacks, never fell asleep driving, so on and so forth. So there's lots of things to, really work with, and some of it, of course, beyond the scope of the primary care providers, and this is why I was having a discussion earlier with somebody about the importance of making sure folks are referred not just for sleep apnea, but for other parasomnias, both mental and physical, to sleep specialists. So the whole management of non-pharmacological treatment boils down to sleep hygiene. And if a person is not attending to their sleep hygiene, if they don't allow sufficient time of total time in bed, keep the same schedule, limit screen time, both phone and computers, limit caffeine and alcohol intake, and the last thing that a lot of people are guilty of, I am too, is laying in bed for longer than 15 or 20 minutes wide awake when you know that you've got very little chance of falling asleep. You know that your mind is racing. We hear complaints of this from people that don't have any other disorders, but they have disorders of initiating and maintaining sleep or just getting to sleep, and then various things can wake them up. But anything that's going to impact the quality of your sleep, whether it's a factor of sleep hygiene or sleep disordered breathing, you're going to have trouble. And I think this may be the one slide deck that did not get the update that I sent last week to Jason, but I'm going to talk through it if I don't run into the slide that I wanted. I had two different versions of this, one that I touched up about 10 days ago and sent through email, and actually the firewall of my hospital may have slid it down, or, edited it. So in the words of patients, we know that there's several recurring descriptions that there's no way to move, there's no way to speak, there's tactile hallucinations, feeling, the presence of an incubus or an evil presence in the room, spinning, and most of all, fear of imminent danger if this is the first time somebody's had an episode. Let me go one more slide, and I'm going to talk through this other one, this edit that I didn't get in here. Okay, hold on just a second. Okay, so the outer body experience in the pop culture that didn't make it into here, there was another slide or two. Does anybody who worked nights in the 90s in here? Nobody goes that? Okay, a few. Do you remember a nighttime show called Coast to Coast, hosted by Art Bell? This was a guy who spent a career He's dead now, but spent a career in broadcasting. And he would go on the air at 1 a.m. Eastern time and go off at 5 a.m. Eastern time. And so by the time you got to the end of your shift, you knew that, hey, it was time to get the patients up and but he dealt with the paranormal. He dealt with Area 51. He dealt with, callers. And now he didn't believe everything that was called in. He was more of an entertainer. He would let people ramble on about everything. But one of the most recurring topics that he had was people that would call in with experiences described as outer body experiences or alien abductions. And it was very entertaining, but if you spin it back to the descriptions of isolated sleep paralysis, some people, lay people in their minds, this really is what this is. This is spiritual, this is an alien abduction, this is all a kind of a pedestrian explanation of sleep paralysis. And as I went through night shift and began reading more and more and coming to conferences like this and learning more about parasomnias, and I thought, well, this guy's made an entire career out of, people with sleep disorders. So, except for Area 51, and that's a whole nother story, but if you want to dig into he's passed now, but back in the late 90s, he wrote a book called The Quickening. And if you've never seen it or read it, it's a quick weekend read. It's really, really interesting. But Art Bell was the guy who got us through the night. But he made a living. Some of the nights he would have people call in. He'd have special lines and special topical nights. Tonight's Monday night, all time travelers call it, just wild, crazy stuff. But the sleep paralysis people made it into. So the consistent risk factors that feed into all this that are widely reported, and unfortunately for young people, even beyond the schizophrenics, your greatest risk is the students. College age and high school age students seem to be at greatest risk. Other contributing factors, of course, that are repeated over and over again include sleep deprivation, poor quality of sleep, any sort of sleep disordered breathing, REM suppression, and deprivation. Circadian rhythm shift work, time zone differences. So for example, if you're one of these fellows that works, or ladies who works for an equipment company, or one of the vendors that we saw yesterday, and you travel back and forth across 3 time zones, ResMed, I believe, is in San Diego. If you work for ResMed, you're all over the board, and you're probably going to have sleep paralysis sooner or later. The findings, though, show that even though the greatest incidence is among females and female college students, actually, it is something that happens in all ages. And it's never completely diagnosed with just a polysomnogram. It's usually a series of questionnaires in a very structured format that elicits certain questions and is packed with screening questions to kind of validate the process. And again, the average, not to belittle physicians, but the average primary care doctor, just like with sleep apnea, they don't want to fool with this. They have follow-up appointments. They want to see so many patients per hour, and they're just not going to take the time to listen to all this. Okay, so send them to your sleep specialist, even though, just like us, there are fewer and fewer of them. The strong psychiatric component, again, includes a lot of these folks, and this first one here is probably what included me before I got on medicine, generalized anxiety disorder. So if you've got folks that are prone to these things, and then possibly a trauma victim of a motor vehicle accident, or God forbid, somebody's a rape victim or something like this, any time that there's an episode of sleep paralysis, that intruder or incubus hallucination could take them right back to that time. And often it does in people that have got PTSD or trauma like that. Okay, I don't think this is going to work, but we can try it. Whoop, nope. Doesn't work. Are you going to try it? What I want to do is try to play this 3.5-minute video of a patient off YouTube that explains his own experience, but in listening to it, if we can get it to play, I wanted you to see if you can pick up on any of the characteristics or symptoms that I described in the average patient. Is it a hyperlink? Excuse me. Okay. The good news is my presentation is not as long as Gabe, so the only thing standing between you and the break is me and about 5 more slides after this. But this topic meant so much to me when I was approaching mid-career, and as the introduction indicated, I've done sleep since 1991, and it's like the baseball guy used to say, it's been very, very good to me. But the fact is that there's fewer of us. There's fewer primary care doctors that are willing to refer folks to sleep. So be an advocate, be active in your community so much as you can. If you're working night shift, I know that's kind of hard to do, but I think it's going to work.
The Wi-Fi is the problem.
The Wi-Fi? Okay. Tell you what, we can skip it. Okay. So this guy who's on YouTube, and you can find any isolated sleep paralysis patient on YouTube will give you the same impression. He has a way about him, a presentation that just looks very anxious, very, people who critique my presentation say very tachypnic, very fast, very flighty. He looks like he's got some sort of disturbance beyond a sleep disturbance. So anyway, you can assign that 30% of mental health candidates to a number of these that are on YouTube, and there's some really good videos on YouTube, again, that are beyond the scope and the time of what we're doing here, that speak to the neurotransmitter logjam. And again, that's hypocretin, the REM on neurotransmitter, acetylcholine, REM off, serotonin. It's a logjam is the simplest way to describe it, but it's treatable. The far-reaching documented occurrences of sleep paralysis are worldwide. They go back for centuries, and some of the cultural beliefs around the explanations include spirits, guardian angels, demons, everything from good spirits to bad spirits, and you can see the different regions and races listed there. So everybody has got, throughout time, their own explanations, and of course, in our day and time now, in the 21st century, for those that really want to kind of stay in the parascientific world, include alien abductions and things like that. So you can find them, they're out there. And the one video, again, is just one of dozens that you can look up on YouTube. So let me take the last couple of minutes to talk about this case study that I did at Memorial and how it turned out, and then we're going to have a brief quiz that we'll talk through just to wrap up and summarize our objectives, and we'll have everything wrapped up probably about 15 or 20 minutes early, maybe 20 or 25, so you can take a good long break and then come back again after that. After the break, Gabe speaks one more time. I forget the topic, but he's so good to listen to. Okay, so in the fall of 1999, after all this stuff had started happening to me, I decided I'm going to find out if I'm the Lone Ranger, I'm the only one to have this happen, or if I'm going to find some other folks that have this and just pick their brain. Well, before I could do that, I ran into this little thing called the IRB. Does anybody know what the IRB is? So the institutional review boards in various academic settings and in hospitals were established to make sure that all ethical considerations are given to human subjects in any sort of experimentation or peer study. This obviously was not a peer study, it was an observational study, but I still had to get approval, and you would not believe what I went through to get it. So I chose a group of folks. It included 64 RNs. Approximately half, I think exactly half, were either 7P to 7A, Baylor, or swing shift. The other half were 7A to 7P. And then, to further break it down, the gender mix is probably about 20%, 22% men, which is about the representation at that time of males to females in nursing. So once they were provided a definition of sleep paralysis, they were given a questionnaire and just, articulated, what all this meant and what all it would present as. And of the people that responded, everybody responded, by the way, and 26% of the group did admit to one incident or more of sleep paralysis. So what that means is, compared to the national average is about 7.6 or 7.8% nationwide. Worldwide, it's a little bit higher than that, actually. Shift incidents, 18, 19% first shift, and then almost double that for third and swing shift. So no great surprises there. It was sort of anecdotal, so this was not, again, a formal hypothesis, and, accepted or rejected or anything like that, that you would do for a thesis or a dissertation. But it took about as much time to do the whole thing as it would to organize and present to a committee the structure for another paper. The data showed that everybody who were night shift workers, whether it was swing or night or Baylor, they had at least one episode many more times in the day shift, and more women than men. And the incidence, of course, is higher than the national average, like I just said, a little ahead of myself. But there are inconsistent sleep schedules, obviously, that you can find throughout healthcare, whether it's nursing, radiology, or respiratory, sleep, obviously. And, all we can do is try to educate our peers as sleep technologists, what good sleep hygiene means, because the National Sleep Foundation, I think, was a little more vocal. Back in 2003, for example, they had a survey that was dedicated, it was called the Sleepiness in America survey, dedicated to nothing but pediatric sleep. And maybe I haven't heard as much about them since the evolution of podcasts and so forth. I don't know that the National Sleep Foundation has kept up with technology and so forth. I barely have. So those folks, have their own agenda and so forth, but they've been a great source of educational material over the years. So, quick quiz, and we'll have about an extra 22 to 24 minutes on your break. So, we just covered this. Recurrent isolated sleep paralysis roughly covers how much percent of the population? 8%, right? One condition that has to be ruled out to aid in the diagnosis of isolated sleep paralysis. Narcolepsy is one of the first ones. The other ones that had been listed on the slides that didn't make it into this during my last edits included hypokalemic periodic paralysis, which is a dietary influenced kind of paralysis. There's other forms of paralysis that are completely neuromuscular and have a genetic predisposition, whereas isolated sleep paralysis, not so much. Now what I'll do, every year everybody leaves their slide deck for everybody. I'm going to include the slide deck with my edits on it that's got much more detail about the co-varying factors and the things that you have to rule out if you really want to make an accurate diagnosis. Okay, so what's one other medical condition that may co-vary with isolated sleep paralysis? Okay, hallucinations. Improvement of sleep hygiene may reduce recurrence, and one pharmaceutical that probably would never be prescribed, but it would help, is basically anti-REM suppressant. And tricyclic antidepressants and SSRIs are usually best. And no doctor really, that I know of at least, there may be some that do, because of folks that have PTSD and real traumatic panic as a response to isolated sleep paralysis, that would give medicine to suppress something that's really such a benign finding. And especially if it's recurrent, people tend to adapt to it. Back in the 90s, before cell phones and the advancement of the internet, people had clock radios on the side of their bed. I can remember vividly seeing the numbers on my clock, but I couldn't move. So, I mean, there's all kinds of reasons to say that it's benign, but to folks that have got a trauma history or something that's far worse than that, it can be much a much worse experience than the average person. So if you want, and again, this is in the slide deck, a list of references that I used to develop this link will be on the slide deck, and if you click it, there's a list of about 18 references that all have various studies and so forth. And when you dive into sleep paralysis, unfortunately, without getting into the cellular and neurotransmitter type of explanations for the rest of it, a lot of the material that you find is repeated. So you find in this list of authors, just lots and lots of replication, but neat topic, interesting to me. And when I leave the slide deck again, I'll leave the picture of Art Bell and all the other stuff about his history and entertainment involvement in outer body experiences that absolutely are, in my opinion, sleep paralysis. But anyway, I appreciate your time. You've got an extra, I think we resume at 10:30, is that right? 10:15. Glad I asked. That's the reason I asked. I appreciate your attention. It's great to see everybody. I see a lot of faces that I remember again and I've seen over the years. And we'll turn it back over to the staff. Thank you.